Professor Dr. R.R. Pal. Thank you, sir.
Good morning, everybody. I am really privileged to be here today to chair the session on Dr. P.K. Basu, one of my most revered, respected teacher. He was not only my teacher, he was my philosopher and guide, and played a large role in molding my career. I almost missed this opportunity because I was informed about this about a month ago by Professor Aditya Mitra, and thereafter I somehow just thought that it was tomorrow, that is 6th. So I prepared myself accordingly. And I just wanted to inquire from Professor Pal whether he is coming on 6th or not. Then he's corrected me, no, sir, it's not 6th, it's 5th. That's tomorrow. So that's how I have landed here. And anyway, so I'm amongst you, and Professor R.R. Pal, he doesn't need an introduction either. I have an opportunity to observe him when he was a student, and also we worked shoulder to shoulder in various platforms like college, then association and council and many other places. He justifies his name. He sees through the subject through his X-ray eyes. And his presentations are laser sharp. Now let us hear him give his laser sharp presentation. Professor R.R. Pal, please.
Thank you, sir. Thank you, Professor Shane, for your very generous introduction. At the outset, I would convey my sincere thanks and gratitude to the organizers of IDA, this conference by the Kolkata branch, especially to the President, Dr. Datta, Secretary, the vibrant Secretary, Dr. Banerjee, and of course to Dr. Professor Mitra for inviting me to talk or deliver the oration dedicated to one individual, none other than Professor Basu. As Sir Professor Shane has rightly pointed out, that when you are in the profession, we are here to profess the profession. A professional person which is assigned and designated to take care of the profession, to take care of himself, to take care of the patients. We belong to a profession. Undoubtedly, the young friends of mine, whoever is sitting here, the bubbling, promising professional of the city of Calcutta, let me tell you one thing. In those days, I'm talking about early 70s, we are grown up in the midst of personality like Dr. Basu. With all due and devoted respect and gratitude to the departed soul, that time she was our idol. She was our mentor. One thing I could learn that time, that if you want to survive as a vibrant professional, you'll have to make yourself presentable. Yes, we are there. Many are there who are competent to make themselves presentable. But very few are there who can command that they are acceptable also. It's not one-way traffic. You make yourself presentable and see to it that equally you are acceptable. And that's the philosophy of a professional person. That the imbibition we have learned from Professor Basu that time, and of course later on with Professor Shane also. Today, I'm supposed to talk definitely about pathology, because I belong to the specialty. But here I'm standing not as a specialist in the field of oral pathology. I'm standing before you as a colleague of yours, as a basic dental surgeon at the best level, so that we can put our knowledge back to practice. When you talk about management, when you talk about diagnosis, when you talk about treatment, have you ever thought that what is happening in today's dentistry? Just I was having a cup of tea there. My young friends are talking about management of practice. Undoubtedly very important facet in practicing life. But dental science, being an integral branch of modern medical science, at any given point of time, we should not forget that we are basically guided, regulated by the concept of biology. We are guided, regulated by the concept of medicine. We talk about evidence-based practice. If you treat a patient, if you assume and treat, the spelling of assume is A-S-S-U-M-E, assume. If you assume and practice, you make you make ass out of you and me. Gradually, we are not to get ourselves dissociated from biology. That's important, very important. Today's dentistry is thriving very good, very promising on two facets. One is based on biophysical, biological, biochemical and biotechnological concept. Other branches are outright biological. You are in the midst of both. So what we have to do? What should be our option left? Let me tell you, the hard tissue pathology, the pathology involving the enamel, dentin, cementum, is more of a pathology than pathology of soft tissues. The language emitted by the hard tissues are more important for dental surgeons, and as dental surgeons you have got to understand that hard tissue language in managing your practice. Practice management in terms of your earning is important. In terms of treating a patient is important. More important in relation to the tissue respect. And that is equally so in relation to soft tissues. In relation to evidence-based approach. With that concept, we talk in terms of as is your pathology, so is your practice. We talk about medicine. You talk about surgery. You talk about treatment. You talk about management. Let us simplify the whole process. The entire world of medicine, of course vis-a-vis dentistry, is like this room only, where you are sitting comfortably. See, in this room, you have got one pillar on this side, other pillar on that side. Right side one pillar, left side another pillar, and the roof there on the top. The normal pillar, that is anatomy, physiology, biochemistry, pharmacology, all normal pillar. Any deviation of normal pillar will lead to pathology, the disease. We talk about disease. If I put it other way around, this is deviation from easiness. That is disease. It doesn't mean only anatomical deviation. It doesn't indicate only pathological deviation. If there is a mental deviation, mental pathology, psychopathology, that is also disease. So any deviation from the normal leads to pathology. What is medicine and surgery? What for we are here? We have to bring back that pathology back to normal with the help of medicine and surgery. That's the roof. The roof is formed by medicine and surgery, normal pillar, abnormal pillar. If you take out these two pillars, you take it out, the roof will collapse. You may be a good dancer in the field of medicine. You may be a competent physician or a surgeon in the field of medicine. But don't forget, you are dancing well on the roof because the pillars are strong. At any given point of time, don't get yourself dissociated from these pillars. That will throw dentistry out of medicine. Now, go back to basics. We are dental surgeons. Yes? We have got neurosurgeons. We have got pediatric surgeons. We have got plastic surgeons. If I put it other way around, in the reverse way, say a neurosurgeon is a surgeon in the field of neurology. A cardiothoracic surgeon is a surgeon in the field of cardiology. If I say, I'm a dental surgeon, I'm a surgeon in the field of dentistry. So basically we are surgeons. Only the field is different, that I'm a surgeon in the field of dentistry. So our motto should be the knowledge-based approach as a surgeon in handling patients in clinical practice. The practice motto, the management motto, the treatment motto, the prognosis motto, everything depends on your biological understanding of the entire science of dentistry. And that's how the young friends of ours will survive better. We talk about progress. Yes, progress is there. Progress was there. Progress will be there. But are you a party to the process with the essence of science, being backed by the concept of science? That's why we say, either you have to progress or you have to perish, nothing in between. You have to progress or you have to perish, nothing in between. So my young friends, good friends, respected friends, the respected crowd, take care. Take care of that part so that in days to come, you can serve better and survive better also. I was asked by the organizers, the time is very short. There is no aim of any discussion, especially when it's in the field of science, especially when it is in the field of specialty. But today I just talk with this preamble concept about 2-3 lesions which may cost the life of the people concerned. That as a dental surgeon, as a base level practitioner, it's our aim to protect lives. Of course, to protect teeth. Yes, you have to protect the teeth. Yes, you have to treat the teeth. You have to make your patient keep smiling, but take care of your patient also. There are certain diseases in the orofacial region which are basically killer diseases. An early diagnosis, vis-a-vis early treatment, early management can save a life. Once I was asked in one of the gathering like this, one young individual asked me, Dr. Paul, how many teeth can be equated to that of a life? I was bowled out. I couldn't give that answer, that how many teeth can be equated to that of a life. He asked the question from the viewpoint that many a times we may have to take care of life through the disease process that is reflected in your clinic by the presence of your patient. Now, the presentation of the day, I'll go in a nutshell. The knowledge of oral pathology, the basis of treatment of oral diseases. The oral mucous membrane, you all know, nothing great in that. The moist, delicate, pliable lining of the oral cavity, of course, other than the tip. The light microscopic appearance of oral mucosa, that also known to all of you. The micro world of oral mucosa, again known to you. It reminds me something very interesting. The good old concept, we talk about clinical subjects, you talk about preclinical subjects, you talk about paraclinical subjects. Yes, that is prevailing in all the training institutions, especially in our country. My dear friend, the concept is changing. Because in evidence-based approach, When you are in a clinic, you are dealing with your patient, you are in the macro level. You are in the macro level, you are dealing with your patients. You are operating, you are preparing a crown, you are preparing a prosthesis, you are conducting endodontic treatment, you are in the macro level. Same tissue, when it is sent to the laboratory for investigation as backup of your clinical practice, that is assessment in the micro level. That means the individuals who are involved in the assessment of the tissue, language is involved, the physiology, the anatomy, the pathology involved, they are also clinicians in the micro level. Today we talk about genetics. Yes? We talk about molecular genetics. So they are dealing in the high-tech labs. They are also clinicians in the molecular level. So the concept is today that clinicians at the macro level, clinicians at the micro level, and clinicians at the molecular level. We all are clinicians at the macro level. But don't forget, you are backed by the clinicians in the micro level and the clinicians in the molecular level who was there behind the screen, and they are giving us the support to dance better in the field of clinical practice. So your clinical practice, let me put a hardcore example. Today in the field of prosthetic dentistry, today in the field of endodontics, it's not the technology advancement only, it is the material science that has created the revolution. The material science has created the revolution. The technology in the instrument base has created the revolution. So the clinicians who are using it, they are using it in a technical level. But actual credit goes to the people, those who are in the micro or molecular or biotechnical level. So we should not forget that. All our salute should go for them. Now, when you talk about oral mucosa, we enjoy in very many ways the presence of mucosa in the oral cavity, starting from cold drinks to hot drinks, as you please. Now this same oral mucosa, when exposed to any persistent trauma, to any bacterial, fungal or viral infections, that imbibes a lot of disease processes, including oral precancer and cancer. And to switch on to discussion, because it is basically a gathering of the clinicians at the macro level, a gathering of the clinicians at the macro level. So I would love to share my experience with you, how you can modulate your clinical practice pertaining to mucosal diseases precisely in the field of oral precancer and cancer in your day-to-day clinical practice. Now, yes, you all know, nothing great in that. If you remember your third year schedule, even in the postgraduate level schedule, you all know about leukoplakia or submucous fibrosis or erosive lichen planus. There's nothing great in that. But there are certain things that needs reorientation, a updated approach. Leukoplakia, by definition, again very simple, an elevated white patch or plaque that cannot be rubbed up or pulled off from the surface of oral mucosa easily. Causative factors, tobacco. Yes, everybody knows. Nothing to be spelled out the poor person standing here. This is all known. Let us visit the tobacco world. What is happening across the globe? India is the third largest producer of tobacco after China and Brazil. Yes, we are. Yes, we are leader. We are in third position in the globe. So far so, the production of tobacco is concerned. Tobacco is cultivated. See the irony of fate. Tobacco is cultivated in 40 lakhs hectares of fertile land, equal to the amount of land used for cultivation of orange and banana. Yes, across the globe. Equal to that land we are using for cultivation of tobacco, the killer product, with production of over 7 million tons every year. Think. India, is the fourth largest consumer of tobacco in the world. Yes, that is our social strata. Go back a bit in depth. What is there in tobacco? If you burn tobacco, what do you get? You get benzopyrene diol which is carcinogenic. This is basically a polynuclear aromatic hydrocarbon. Functions. Simple function, complicated functions. At the macro and molecular level. The molecular function, it binds to DNA and cause genetic mutations. That is because of polynuclear aromatic hydrocarbon which are toxicated to mutagenic epoxides. Benefit? I know probably there is nothing other than a bit of stimulant. But what about youngsters today? Many youngsters turn to tobacco use because tobacco increases the metabolic rate, metabolism in the body and suppresses the appetite. Yes? Prevalence of smoking of tobacco. In 2000, smoking was practiced by 1.22 billion people, increased to 1.45 billion people in 2010, and predicted to be 1.9 billion by 2025. Yes, presently about 20% of the young teens, that is 13 to 15, smoke worldwide, with 80,000 to 1 lakh children taking up habit every day across the globe. About 1 lakh of the young children are taking up that habit. We, the dental surgeons, as you handle your patients in the clinic, you talk about preventive part of dental caries, you talk about preventive part of periodontal diseases, you talk about preventive part of dentofacial anomalies. Let us look back. Why not to talk about tobacco prevention in the clinic on regular basis? Because you are the person, you are the individual who can fight against these fatal approaches being adopted by the people around in early age. The clinical presentation of oral leukoplakia, I'm not going into details of it. The clinical types, yes, it makes a difference. Somebody thinking there may think, what is great in that? Why to know about clinical types? Yes dear, it makes a lot of difference. It makes a lot of difference. Once you know the type, accordingly the prognosis varies. The prognosis of homogeneous leukoplakia and prognosis of an ulcerative or nodular leukoplakia is distinctly different. From that angle, you have got to judge it. This is the clinical appearance involving the cheek or the tongue. I'm not going to point it out. The ulcerative leukoplakia, this is something important. See, this leukoplakia and this leukoplakia makes a lot of difference. Here, this white patches, this red patch is very indicative. This is interpassed with so many nodules, interpassed with red patches. Let me tell you one thing. Every disease, as you talk, many times you talk, many times you look at somebody and you say many things than being spelled out. কিছু না বলে অনেক কিছু বলা হয়ে গেল, জাস্ট মুখের দিকে তাকালেই হলো। You spell many things out. Same thing here in relation to the disease process. Every disease has its own language. Every disease has its own language. And you being a clinician at the macro level, you have got to understand that language of the disease process, and that is pathology. The disease you touch. Say, I want to make friendship with anybody. You go for handshake, you touch the hand. You touch your hands together, put your hands together, not your hand, with your friend. The very expression will tell you whether you are accepted as a friend or you are not accepted. You put your hand with your friend, maybe a girlfriend or a boyfriend, you touch the hand, you know whether your friendship is accepted or rejected. Same thing here in the disease process. In case of diseases like this, leukoplakia and lichen planus and submucous fibrosis, your finger at the macroclinical level will act as the sensor. You touch, you know what is happening underneath. You touch the lesion, you know what is happening, and then you are really a good clinician at the macro level. These are in the angle of mouth. This one is more dangerous than this one. The reason is pathology. Of course, I am not going in details, but if you get a lesion like this, be careful than the lesion like this. Histopathology with varying degrees of epithelial dysplasia. You go to micro level. This is the usual histopathology. As you see under microscope, this is the schematic diagram. Here you see the cells there at the base level. This is your connective tissue. This is your epithelium. This is the surface showing parakeratosis. Here you see in the schematic diagram, the basal cells are showing all features of cellular and nuclear atypia. Right? And that's the features you have got to note down. Here in intermediate type, see the changes are there involving the surface layer from here up to this layer. You see how it goes. Here the same abnormal changes are from here up to the topmost layer. That is, you put it as high risk cases. The case where the dysplastic changes are there only in the basal layer here and involving this basal layer up to the mid zone and basal layer to the top zone or the surface zone, this will spell more aggressive nature of the lesion, and it is likely to get itself transformed into malignancy much faster than the other diseases. So accordingly, you take a biopsy and see to it that what is the degree of changes. Accordingly, you can decide your clinical prognostic part. This is for the pathologist. Basically, how the changes in the cellular level takes place, whether it is in the prominent nucleus here, or what you call altered nuclear cytoplasmic ratio, or what you call the nuclear pleomorphism here, and there's a giant nuclei or multinucleation. These are the features. These are the features you have to note in consultation with your pathologist. They'll tell you which way to go, and you do it. You play safe. As a clinician in the macro level again, we usually deal at this level, normal. From there to dysplastic, varying degrees. Ultimately, the aggressive dysplastic status, what you call erythroleukoplakia or speckled leukoplakia. The variations from normal gradually transfer. Schematic diagram to give you an idea what is going on at the tissue level. The differential diagnosis, simple. I'm not going in details about it. The malignant potentiality, about 26% of the leukoplakia diagnosed in the clinic turns into malignancy. So you can save, out of 100 cases, you can save the life of 26 patients that way. What you are eager to know, the treatment. Yes? With this background knowledge, you go for treatment. Treatment of all precancer or pre-malignant disorders, as on date, has been divided into two phases by WHO itself. Phase 1 and Phase 2. Phase 1 treatment is with all practicing base level dental surgeons. With you. Phase 1 treatment. Phase 2 treatment, of course, requires specific knowledge. That I'll discuss. Now the Phase 1 treatment is common for almost all the precancerous diseases and disorders. In the Phase 1 treatment, the first phase here, stoppage of all oral deleterious habits. First thing, don't institute the treatment without stopping the habits whatsoever as the causative factor. You go for routine hemogram here. Routine hemogram, especially hemoglobin percentage and blood sugar level. Remember, anemia is one of the very proactive factors. An individual having oral leukoplakia without anemia, with anemia, will prone to malignancy faster. One individual without having diabetes mellitus being suffered from that, another individual having diabetes mellitus will imbibe a lot of infection and foster transformation from the normal to malignancy. Then, once this being achieved, you go for exfoliative cytology. Very simple procedure. I'll come to that. Very simple procedure. Any clinician at the macro level in the clinic can do that. There's nothing great in that. Very simple procedure. We'll come to that. You take a smear, go for H&E or PAP or PAS evaluation. Right here, PAS is very important. PAS evaluation is to rule out candidal infection. Any pre-malignant lesion having superadded candidiasis, the propensity for malignant transformation increases very fast. Without candidiasis, with candidiasis, it will make a lot of a difference. Now you have got to identify that whether the lesion is in association with candidiasis or without candidiasis. That can very simple done in a cytology with PAS evaluation. Then improvement of oral health, mouth preparation what you call through prophylaxis. Don't treat mucosal lesions without improving the oral hygiene, the basics. You go for improvement of oral hygiene. Through prophylaxis, obvious, and home care as the case may be. Then treatment of the diseases if it is there. Treatment of candidiasis, diabetes mellitus, anemia, and correction of nutritional deficiencies if any. Again the same thing. If these diseases are there, in that case you treat all this, talk to your physician, go for interaction, go for multi-speciality or interdisciplinary approach and take care of the patient in terms of candidiasis or diabetes mellitus or anemia or nutritional deficiencies. Don't close your eyes and prescribe something. Then reassess clinically. Yes, you are the judge. You are the best judge there. Once this preventive part is done, you reassess. Reassess the status of the disease. If the disease persists, proceed to phase 2 treatment. Now in phase 2 treatment of oral leukoplakia, what you have to do in the clinical level, in your clinical practice. Now, clinical diagnosis has already been made by you. Clinical diagnosis, I don't mean to say light microscopic or ultra microscopic diagnosis, I mean to say the clinical diagnosis. Now, once you complete the clinical diagnosis, if the lesion goes off, yes, only periodic follow-ups. If the lesion persists here, if it persists, small lesions, go for excision. If it is less than 20 millimeter or so, if a large lesion, you go for toluidine blue screening. Small lesions, as I said, here you can go for excisional biopsy, see whether there is dysplasia, whether there is no dysplasia. If there is mild or moderate dysplasia, after excision you wait and watch. If there is a severe or moderate, in that case you can get into the next phase from there to this, right? The large lesion, you go for toluidine blue screening. If a lesion is there involving whole cheek, entire dorsum of tongue, how from to take a biopsy? Very simple. Anybody can do a biopsy. There is a myth. Let me tell you, there is a myth in clinical practice. Yeah, biopsy is to be done by that person only. No, you are more competent to do a biopsy than anybody else. Let me tell you frankly, you need just little bit of teaching and training. In that case, to perform a biopsy is nothing, very simple. Much more simple than doing any other job in clinical dentistry, what you call. What do you need? You need to select the right site. Site selection is very important. There are methodology. That is called your toluidine blue assay. You talk about the toluidine blue assay. You paint the lesion with toluidine blue, decolorize with acetic acid. Wherever the dye will be persisting, that's the right site. Because we say biopsy is not to be done from any site of your choice. It is to be done from representative site. So selection of site is very important. Selection. How do you select? Through toluidine blue screening. Select the site, go for a biopsy and see the degree of dysplasia. Of course, that is the micro clinician or clinician at the micro level will be your friend. They will tell you, yes, it is mild or it is moderate or it is severe accordingly, or it may be a carcinoma also. Now, many lesions may appear innocuous. Clinically, it's a simple white lesion. Clinically, a simple red lesion. But underneath that, it may be a frank squamous cell carcinoma. It happens. That is the hard reality of clinical practice. Other disease, submucous fibrosis. By the way, Dr. Banerjee, I can continue up to 12, 10 or 15. You said 15, now 10. Later on 12, 5. Okay, that's it. I'm sorry, I'll finish it. Don't worry. Now, submucous fibrosis. Because after all, his order is the final, okay? I'm nobody here. Now, the disease incidence or prevalence. The causative factors. Unlike tobacco, chewing or smoking, submucous fibrosis is precisely related to betel nut and allied products, especially the so-called pan masala. Now, in India, you know what is happening? Many times, we cannot smoke in front of everybody. But there is no bar in chewing something. I won't dare to have a cigarette in front of Sir, Professor Shen. But I don't mind to have a pan masala in my mouth and talk to him like that. So what is happening, the youngsters, even in the residence, they are picking up this habit very fast. This disease is now becoming epidemic in India. Yes, it is epidemic because of that concept. Arecanut is the causative factor. The paradigm of the process I'm not going to discuss because of shortage of time. The clinical features are known to you again. The clinical appearance is also known to you. Only you have to note that here, see the soft palate and nodular uvula and depapillation of tongue. Any submucous fibrosis cases showing depapillation, any submucous fibrosis cases showing interpassed with erythematous patches, take it seriously. Histopathology, maybe without dysplasia, maybe with dysplasia. Many a times, innocuous submucous fibrosis may reveal dysplastic changes like this. See the dysplastic changes here under microscope. This is non-dysplastic form, this is dysplastic form. Here, as a clinician, you have got to take care. Differential diagnosis. The malignant potentiality, yes, about 6 to 8% of submucous fibrosis develop malignancy. Yes, that is very important. Phase 1 treatment, same as that of leukoplakia. Phase 1, there's nothing additional except a bit of care relating to the opening of mouth, trismus. You cannot approach to achieve everything there. Then treatment. Treatment, let me confess, as on date, it is very unfortunate. If it is in the so-called clinical gradation, grade 1, grade 2, even grade 3, you can think of. Some treatment is there in the palliative form. We don't have any curative treatment of submucous fibrosis. Even if our surgeon friends, what they are doing, they are chopping out the fibrotic bands with the idea to increase the opening of mouth. Mouth opening is increased, but disease is not being treated. Two aspects. To increase the mouth opening is one aspect. To treat the disease is other aspect. To treat the disease as a dental surgeon, you have to take care after elimination of all the allied factors. You can think of a bit of treatment if it is not having any dysplasia. If it is having dysplasia, things become different. If it is not having dysplasia, things become easier. And in that process of treatment, the preventive and palliative treatment is more important than aiming for curative treatment. And all patients must be periodically followed up. Say you get a patient suffering from cardiopathy, a patient suffering from, say, diabetes mellitus. The physicians concerned or cardiologists concerned, they are calling back the patient repeatedly every 3 months or 6 months interval. You as a dental surgeon, call back your patient. Whoever is having leukoplakia or submucous fibrosis, call them back. Go for a periodic interactions and see to it, look through, there is no ulceration being developed, no erythema being developed in a particular case of submucous fibrosis. If it is just homogeneous whitish appearance something, if it is having any nodular growth, having erythematous changes, having ulceration, think twice before you say goodbye to your patient. And in the process, of course, we prescribe a lot of micronutrients or the sertraline tablet, these are all good old methods, but the vigilance, periodic evaluation is more rewarding. Go for lichen planus, immunologically mediated disease. Earlier we thought it is nothing in terms of pre-malignancy. Today we talk about pre-malignancy, about 0.5 to 2% of oral lichen planus cases, especially the erosive lichen planus transformed into malignancy. Etiopathogenesis, not of importance for the crowd. Clinical features known to the crowd. Clinical appearance known to you. One thing to make note of it, that when you have this reticular lichen planus asymptomatic, you can wait and watch. But a reticular lichen planus today gradually turns into what you call atrophic lichen planus with erythematous base, or what you call plaque type or erosive lichen planus, as this case is, erosive or plaque type or atrophic lichen planus, from a pre-existing reticular lichen planus. When there is an erosion, any ulceration or atrophic changes, put your finger crossed, take care. Differential diagnosis, microscopic appearance. Yes, this is the typical histopathological appearance of lichen planus, where you could get a cleavage, you can get the band-like infiltration of lymphocytes, etc. You can get a cleavage, epithelium to the connective tissue, subepithelial cleavage. Today, diagnosis is more based on what you call immunofluorescence assay. Yes, today we think of immunofluorescence assay, not only the histopathology, immunofluorescence, which will differentiate your lichen planus from pemphigus or pemphigoid or erythema multiforme. They appear alike, right? Now, as you talk about differentiation between typhoid or malaria or dengue, the same thing here, you can go for this type of differentiation with immunofluorescence assay, where the fibrinogen here will have a typical shaggy appearance. The differential diagnosis, the malignant potentiality, yes, about 3% turns into malignancy. Phase 1 treatment same as that of lichen planus or leukoplakia or submucous fibrosis, just a bit difference relating to the disease process. Then you get into the treatment proper, where you have got to symptomatic and asymptomatic. If your lesion is asymptomatic, you can wait and watch. If it is symptomatic, mild or moderate or severe, mild, moderate, you go for topical steroid, especially triamcinolone acetonide. There are a lot of products available in the market. Your representative friend, being on the other side of the boat, will come and tell you so many things. But think one thing, for any drug to be effective, once you apply the drug in the mucosa, the drug must have to stick to the surface, at least for optimum period, to be absorbed. If you apply the drug, it is washed off by the saliva immediately. The drug is never ever absorbed or adsorbed, as the case may be. So you need to have an ointment which is basically a triamcinolone acetonide or fluocinolone derivative that must stick to the surface. That means it must be in a sticky base, what you call the ora base, not in a greasy base or plasto base or like that. So you should be very careful in selecting your drug. When the disease is very severely symptomatic, you can think of sublesional injection with, again, triamcinolone acetonide as immediately depicted here. And in doing so, the lesion may reveal improvement, but be careful to see to it that there is no persistence of ulceration, there is no persistence of a granular or nodular lesions. Yes, we'll go back now to cancer. This precancerous lesion can turn into malignancy, that is oral cancer. Yes, you all know, but today the definition have changed. We talk about genes, so defining cancer is, it's a disease in genes. It's a disease in genes that encodes proteins, that controls cell cycle, cell motility, cell survival, and angiogenesis. So the definition means the conceptual evolution of cancer anywhere in the body, including oral cancer, have changed on the basis of genetic concepts. Prevalence, yes, we talk oral cancer. India is the king. Yes, we are on the top. Now globally, in many of the meetings in global level, they talk about Indian cancer. Oral cancer has been renamed as it is Indian cancer. It's not oral cancer because we have got the maximum number. We are having about 80,000 individuals affected with oral cancer annually. Where about 80 million Indians are developing precancerous lesions, potential cancerous patient. See, what is the irony of fate awaiting for us? There are certain epidemiological facts. There is 60% increase in the prevalence of oral cancer in the last 3 decades. 60% increase. Highest mortality rate compared to other malignancies. 92,000 new oral cancer in India every year. 50% of the patients diagnosed die within 5 years. Yes, we are having a lot of modalities. Have you ever thought of what is the end result of it? You talk about mutilating surgery, you talk about microvascular surgery, you talk about reconstructive surgery, you talk about coupled with radiotherapy and chemotherapy. Have you ever thought what is there after 5 years? Very important. The results are very good provided it is diagnosed in the early phase. If it is diagnosed in a late phase, whatever you do, most of your patients will die by 5 years' time with recurrence. When you cut hair, performing surgical procedure, some of the tumor cells sitting in the liver or in the lung will smile at you. Come on, cut it, man, I'm here. You go on cutting, doing anything, everything. But the cells already, who has gone metastasis, what you talk about micrometastasis today, sitting in the lung or sitting in the liver, will laugh at us. So you are more important. It is not the oral pathologist or oral oncopathologist like me, or not oral surgeon or chemotherapist or radiotherapist are important. No. I precisely say you are the most important facets in that clinical practice. It is you to develop that clinical eye. You have to develop that clinical finger which will tell you that this is precancer turning into malignancy. So take care at that level, the life will be saved. This is just an idea to you. Initially you thought microbes has got nothing to do. Today, my dear friends, the concepts have changed. That is, microbes are silently playing very important role. So oral infection, where you get billions of microbes. Basically, I should precisely tell you, there are microbes, 3 categories broadly. Whatever is there in the book, forget it. For us, in practice, clinical practice, 3 different categories. One is non-pathogenic, commensal microbes, very important for us. Second group is pathogenic. Their characteristics known that they are pathogenic, they will create some disease. And facultatively pathogenic, the third group, the most opportunistic group, treacherous group. Their activities are unpredictable. So the non-pathogenic group and the pathogenic group, one way or other, we are known, we know. But the facultatively pathogenic group are very treacherous. And especially in terms of carcinogenesis, these facultatively pathogenic groups, including Candida albicans, are playing very important role even in DNA level changes, mutation of cells. So the concept of carcinogenesis, development cancer, is now being intimately analyzed in relation to oral infection. So we go back to the basics, very base level, very basic clinical level, improvement of oral hygiene. Get your oral hygiene free of microbes as far as practicable, especially when you are having patient suffering from pre-malignancy or malignancy. The age, sex, etc. is not that important. The clinical appearance of different types of carcinomatous lesions, you must have faced it in different angle. Here, this one is important. See, this appears to be innocuous. This is cancer, anybody will say. This is hiding itself. You hide. You laugh, smile, but inside you are aggressive. See, clinician will have that access. What is there behind the smile? There is something treacherous behind the smile of the lesion, as in these particular cases. You may ignore, ठीक है चलो इसको छोड़ दो, नहीं, be careful. See the tongue lesion here. This is exophytic growth. Anybody will appreciate. This is invasive growth. Anybody will appreciate. But what about this lesion? Just red patch with sort of reddish erythematous base with some patchy white areas. Otherwise normal. No anatomical deformity. Somebody will think of, okay, leave it. No. Be careful. Here, the ideal cases to go for cytopathological evaluation. Now this is histopathology, microscopic world. Anyway, left for the pathologist, and our treatment modalities as surgery, radiotherapy, chemotherapy, because this is not the right forum to discuss all that. I'll switch on to screening modalities, what you can do. We can screen the precancerous lesion or cancerous lesions in modalities like, first is clinical evaluation, it is with you. Second is the radiological and imaging information. Yes, radiology today is coming in a very big way in diagnostic field. As you talk about CBCT today, diagnosis of RCT patients, etc., my dear friends, in no time, the radio imaging processes will even replace microscopy. Yes, we are in a position now, even the newer technology is there, knocking at the door, is OCT, optical coherence tomography, non-invasive procedures. That is a field jointly being worked out by the pathologist and the radiologist together. That is the system biology approach. Today's medical world is talking about system biology approach. We don't talk about practice that I am the boss. No. We join hands and then become a boss. Yes, interdisciplinary approach, multidisciplinary approach. And that's what is coming up today in relation to radiology and imaging in the field of oral oncoradiology also. Yes, it is there. Now, you talk about cytology, you go for exfoliative cytology, you talk about brass biopsy, you talk about aspiration cytology, that is conventional or CT guided or if what you call guided cytology, or you go for biopsy, incisional or excisional, right? Or you go for frozen section. Yes, that all known to us, right from clinical evaluation to biopsy, known to us. Sorry. What about the advanced methods? Today, we are putting more stress on this. That is immunohistochemistry, immunofluorescence, and molecular oncology. Yes, the dental scientists, I should say, the dental surgeons, I should say, and the scientists from the field of dental science itself, they are no less. Many of the scientists across the globe from the field of dental science are leading very many centers in the globe for oral oncopathology research. Genetics in oral oncology is being led by the scientists in the field of oral biology. Yes, you are very much there. The cytology, the procedural part, exfoliative cytology, procedure as I have already described, very simple, right? Here you see the cells from the surface. For time is very short, I've got only 10 minutes, otherwise Dr. Banerjee is going to fall on me heavily. So to make him happy, I've got to cut short my journey. Yes, you get the cells. You study the cells under microscope. Here you have to take the help of your pathologist friend, who is a clinician at the micro level. This is a normal or colored, see, the orangophilia as you talk. This is a normal one, this is orangophilia. Yes, color changes. অনেকে বলে না যে মুখটা কথাটা শুনে মুখটা খুব চোখ মুখ লাল হয়ে গেল, that indicates the cells also have got their own language, and you have got to judge this with the changes, their morphological changes, nuclear changes, hyperchromasia, nuclear pleomorphism. All these are important facets in cytology, and your cytology is more tough than histopathology. Then biopsy. Few years back there was furor about brush biopsy, what not. I'm sorry. That's again indicative. Never ever be confirmative. That indicative. You go for branch biopsy itself, the same. Because it is confined in the epithelial level without showing any innervation to the subepithelial connective tissue. You go for FNAC. Yes, in your clinic you can do it, very simple. You got a lump, you got a lesion, space occupying lesion. As you talk in clinical practice, SOL, S-O-L, right? Space occupying lesion. If you are a good clinician with good knowledge in anatomy, very simple, in aseptic method you go for aspiration as is being done in this case. Right? You do that. Send it for evaluation. And there you can go for analysis and diagnosis, but it has its own limitations. That falls in pathology. Finally, aspiration again has revealed real good microscopic picture where you can say this is cancer. Right? Now, welcome sir. You go for biopsy, surgical removal. As I said, biopsy is not the procedure to be performed by anybody, everybody, but by dental surgeon. Yes, that's your domain. You work hard. You learn the process as you go for updating. Updating in crown brace, updating in endodontics, updating in implant. Why not updating in a biopsy? Because that updating, you're updating in endodontics, updating in crown brace, updating in implantology, will save the teeth, will preserve the smile of your patient, will make you happy also. But my dear friends, if you know how to do a biopsy, very simple, and as a dental surgeon you are very competent, very knowledgeable to perform that in your clinics itself, that will save many life. Me saying so is that try to save life also, not only to save the teeth, try to save the lives or lives of your patients also, and keep the family smiling. This is the simple one. Here in the tongue you got a very simple lesion. It appears innocuous. Toluidine blue assay, point the biopsy, see the malignancy. The lesion was hiding. The lesion was just a white lesion here. In the sequential event after toluidine blue assay, it has turned out to be a malignancy. Yes. When there is a big lesion, any growth, in my Guru Nanak Institute, I got one GDA, Rajkumar. He will come and tell me, sir, lagda hai kuch gadbad hai. Patient aaya, sir, gadbad hai. That means in his level he can make out there is a lump, there is a big swelling. So nothing great in diagnosing a patient with a big swelling. It is your credit to diagnose in the earliest level at this level, not at the level having a very fungating growth. You go for excisional biopsy, plant, simple procedure. You go for frozen section, of course, specialized procedure. The cellular and nuclear atypia, innovation, etc. again for the clinicians at the micro level. These are histopathological pictures showing the varied appearance. I am not going to discuss it because there is real acute shortage of time. Advanced modalities. Yes. Today, as I told you in the beginning, you have got to progress or perish. There is nothing in between. You are in the field of profession. You are a professional scientist. So you have got to progress or you have to perish. Naturally you will be eliminated. Yes, you have got to update. So, updating in totality. Yes, in that it is our responsibility to update and adapt to the advanced method. And in that we are having a lot of immunohistochemical procedures today. And we do that, we practice that regularly, and we can make out even the hidden cases where it is being proved as malignancy or old cancer. Now, this is the tail end. Still 2 minutes time to go. I'll finish it. The thing is, see, we are there in the clinics, clinical evaluation. Beyond that is microscopic evaluation. Beyond that is molecular evaluation. What I mean to say, today we have to grab not only or act not only as a clinician at the macro level, then clinician at the micro level, then clinician at the molecular level. So here you are dealing the changes. With microscope you are reaching to this, with molecule you reach to the level. Right? So your clinical approach should embrace all three facets, macro, micro and molecular facets. Yes, 50 years have gone since the parameters of oral cancer was analyzed. We are still unable to crack the nut. As I told you, that the end result is death. It's my appeal to my friends here, all my colleagues here. As a surgeon in the field of dentistry, I put it other way around again. You are a surgeon, like a neurosurgeon, like a cardiothoracic surgeon. You are a surgeon. You are a surgeon in the field of dentistry, not a dental surgeon. You are a surgeon in the field of dentistry. So act as a surgeon at the base level and see to it that the incidence, prevalence, progression, treatment, management of oral precancer and cancer is adequately taken care of. I convey my sincere thanks to my colleagues, Dr. Moushumi Paul and Dr. Sanchita Kundu, for their help in preparing this.